morning. As everybody, make sure you sign in so you get CME credit and CEU credit. Welcome to our October grand rounds for physical therapy, and I'm very glad to see that the program's growing. Next month we actually were able to capture the lecture room, so we will have a little bit more seating next month. And thank you to Joe Patinella for that. We're going to start today with a very quick intro about Capital Blue Cross quality improvement by two of our residents for about 5 minutes, and then we're going to switch off to to what all of you guys came for, which is the foot and ankle program. Okay, so let me turn it over to Dr. Cornell and Dr. Adrians, and there you go.
All right. Good morning, everybody. Just like Steve said, we're just going to talk briefly about the quality improvement project that Jen and I are doing. So objectives, just understand this tiering system utilized by CBC, understand the CBC utilization versus what we're finding in photo, and then finally understand fee-for-service versus bundled. So insurance, currently we're under the fee-for-service model, meaning each CPT has its associated charges as we've been billing. Due to overutilization, insurances have initiated caps or authorizations for the insurance for patients to come in. So Tier A for CBC, currently there are no St. Luke's locations under the Tier A category. Typically in Tier A, you don't need to gain authorization. The providers are only limited by the patient's insurance cap. And typically those who are in Tier A are using 6.5 visits per patient. Currently in Tier B, we have Allentown and Anderson. In Tier B, you do not need to gain, Tier B, you need to gain authorization. However, this can be completed by the front desk staff. So there is no medical review required. They just submit to the CBC, and typically 6 visits are granted. So with this, there's still a date range that they have to utilize those 6 visits in, and people who are in Tier B are typically using about 8 visits per patient currently. Finally, for Tier C, we have Bethlehem and Quakertown in Tier C. For this, it's arduous. You have to go into Navinet. You need a medical review, or you need to do an updated plan of care each time. From there, CBC is then going to look it over and then look at medical necessity and then grant you the visits based on the patient's medical necessity. Again, with this, there is a date range attached to that. I'm going to turn it over to Jenna.
So at this point, you're probably saying, okay, what do I do with all this information? Why do I care? So for us as clinicians, being in Tier B has clear advantages. So not having to submit a plan of care to gain authorization means that the front desk coordinators are really easily able to do this for us, and we don't necessarily always have to perform a re-eval for every authorization. We also get that feedback back right away, the authorization back right away, which means that there's a much less chance of getting denials and missing authorizations. As a healthcare system, we're also moving towards a more bundled payment system, meaning that, and I'm sure our friends in inpatient are pretty aware of this, meaning that we will be reimbursed for how efficient and for the quality of care that we provide, as opposed to the fee-for-service model, meaning that we will be rewarded for doing things more efficiently. So the CBC tiering system isn't the only feedback that we as like an organization have received concerning our utilization. If we look at our photo scores, up here you can see this is the column that looks at the number of visits that we use as compared to the national data, and we overutilize or use more than the national data by about 2 visits in all orthopedic categories. So I know you're probably thinking, well, we do a really good job, which is true, but eventually as things progress forward in the healthcare system, both of these are going to be pretty important. So I think it's good that we just become aware of it. So what are we recommending? We're not recommending, or how close were we actually? So Bethlehem, last time CBC kind of did this tiering system, used about 8.1 visits per patient. So if you remember, the cutoff this last time was 8 visits. So we were very, very, very close. Quakertown was also very close. So it's not like we need to cut the amount of visits that we're using in half. I think just simply being more mindful, if we cut one visit here and there, would probably put us into that tier B with all of those advantages. What are we recommending? We're not recommending that we prematurely discharge patients. That's not at all what we're recommending. We're just recommending that we become more mindful about the way that we're utilizing visits. Making sure that every patient is progressing during every visit, that they're not coming in and simply running through an established exercise program, that if they're independent in what will likely be their final home exercise program, that you consider discharge. And also thinking about those early surgical patients that come in like a shoulder patient that really isn't able to be progressed significantly in the first 3 weeks, that we don't utilize a lot of visits during that time because they likely do not need them. And just really making sure that our patients are being adherent to their home exercise program, because that will allow a quicker progression and utilization of less PT visits. So in summary, just simply reflect on what you're doing on a day-to-day basis. Make sure that every visit is truly meaningful. This should hopefully result in all of us being placed in a tier B category, which will result in a lot less effort on our end and a lot less paperwork, and hopefully lead to less denials. It'll also help us prepare for future changes in healthcare and ensure higher quality of patient care. Does anybody have any questions? All right. Without further delay, thank you for listening, and we'll turn it over to Dr. Matt Babbitt.
All right, Dr. Matt Babbitt, here you go.
All right, thanks for coming out, everybody. Actually, I think maybe the next hour we just talk about capital for the rest of the time. I could go on and on, but thanks for coming out on this dark, cold morning. Kept thinking I had the wrong time because it was so dark this morning. But anyway, so we're going to talk about biomechanics of foot and ankle and orthoses. So have a lot of material to get through. So we should be able to get through it by about 10 or so. So hopefully nobody has patience this morning. Just kidding. Okay, we'll be done at 8. All right, I have to say I have no financial relationships to disclose, and Steve did promise I could have a bagel after the talk. So, all right. Okay, our objectives. We're going to look at some basic anatomy. We're not going to go into too much depth just from a time standpoint. Also going to look at the relationship of the foot function to hip and knee, really the lower chain altogether. We'll go through a basic lower extremity screen that I think will be helpful clinically, and we'll look a little bit at foot orthoses. All right, so to dive right into boring anatomy, there's 28 bones in the foot, so it's a complex structure. With all those bones, there's a lot of joints. So if we divide it up into 3 parts, it makes it a little more reasonable or easy to remember. But basically, it's comprised of a forefoot. So down here, forefoot, midfoot, and the rear foot. So the forefoot is metatarsals and phalanges. Midfoot region are the cuneiforms, cuboid, and navicular. And then the rear foot is the talus and calcaneus. Okay. Ligaments, you all know, we don't need to spend too much time going over those. Just one interesting point about the ATFL, obviously very commonly injured in lateral ankle sprains. Mulligan will say that in the majority of lateral ankle sprains, the ATF is not really involved. It's more of a positioning or a pull on that fib. So just an interesting point there. But I'm sure we're all familiar with these ligaments that we deal with on a regular basis. All right, so let's keep moving on here. Ankle joint, so the talocrural joint, basically made up of the tib, fib, and talus. So you have the mortise. Whoops, wrong button. All right, so you got the mortise down here. Okay, the talus sits in that mortise. Primary motion is dorsiflexion and plantar flexion. Okay, there's really no inversion, eversion at the ankle joint, which again we all know, but that's kind of a common misnomer. And there is also slight movement in the transverse plane just because of where that axis sits. So remember that motion occurs perpendicular to the axis, so since it's at a little bit of a diagonal angle, you're going to have some transverse plane there as well. So limitation in ankle dorsiflexion is a big deal. I'm sure we've all seen that in the clinic. Some of the limitations could be soft tissue tightness, gastrocsoleus complex could be tight. You also have some ligaments that are going to restrict motion, and it's possible that the talus could be blocking motion as well.
Sorry.
Oh, hi, Sarah. Can she hear me?
Yes, she can.
Okay. Hi, Sarah. Okay. I can see myself. Oh. Okay. All right. So again, Mulligan promotes the posterior fib or posterior talar glide, which is very useful in these cases where dorsiflexion may be restricted. So that's one that I like a lot and we use frequently. Okay, subtalar joint. Articulation between the talus and the calcaneus. There's 3 facets that actually articulate. And it's a triplanar motion. So there's motion occurring in 3 planes, which is what makes it complicated. It's not just a simple hinge motion. The ratio is anywhere from 2 to 4 to 1, supination to pronation. And the important thing here is that this allows rotational movements of the leg. Also, it allows for the adaptation of the foot on uneven surfaces. So that's an important one. Again, the axis average is 42 degrees of inclination from the transverse plane and 16 degrees from the sagittal plane. And the important thing here is the axis is, depending on how that axis is oriented, will determine the motion. So not everybody is the same. So you can't say, well, they just, they should have more motion than that. Really, if the axis is in a different place, that's all the motion they're going to have. So this slide, I don't know if you can see that very well, but the top one here. So if you notice, this is a little bit more vertical. Okay, this is a little more horizontal, and then this is kind of in between. Okay, so this one is considered to be normal. And again, there's one of the problems with foot and ankle is we really haven't come to any real strong conclusions about what is normal, which is nice because we don't have to be normal. But anyway, so up here, when the axis is vertical, if you think about the motion occurring perpendicular to this plane, there's more of a rotation component. Okay, forefoot abduction, adduction. So less inversion and eversion in response to rotation of the leg. And from a clinical standpoint, these kind of people may have more leg or postural complaints. If it's a little bit more horizontal, then you're going to get greater inversion, eversion. Basically more of that typical pronation, supination that we think about. And from a clinical standpoint, then you're going to see more of the foot abnormalities. And again, this is sort of in between the best of both worlds. Okay? All right. So mid-tarsal joint, also called transverse tarsal joint or Chopard's joint. It's the combination of articulation between the talonavicular and calcaneocuboid joint. This is the functional articulation between the hindfoot and the midfoot. So it's bringing everything together. There are 2 distinct axes here, longitudinal and oblique. So, even at the mid-tarsal joint, this small area, we have 2 axes with motion at both. So again, this kind of adds to the complexity of the motion and mechanics of the foot. So longitudinal allows inversion, eversion. The oblique axis, so longitudinal is here, oblique axis here. The oblique allows dorsiflexion coupled with abduction and plantar flexion coupled with adduction. Okay, so first ray is also an important structure in the foot in terms of function. It's basically made up of the first metatarsal, medial cuneiform, and a navicular. The motion here is basically dorsiflexion and inversion, as well as plantar flexion and eversion. This comes into play. Sometimes you can have a hypermobile first ray, where the first ray is not really doing much support in terms of weight bearing. So then stress gets transferred to the other metatarsals. So the second metatarsal might be overstressed. You might get some metatarsalgia or possible stress fractures. You could also have a plantar flex first ray, where there's not much mobility, and it's going to make the foot function a little bit differently. So it's something worth looking at. And just briefly to point out the windlass effect, basically a mechanism where the tarsal joints are passively locked together so that the foot can become a rigid lever. And it requires dorsiflexion of the toes for this to happen. So again, as we walk, the foot pronates to, in a pronated position, the foot is supple, it's soft, it can absorb shock and absorb to changes in the surface. It also needs to revert back to a supinated position so it can lock and become a rigid lever for propulsion. So this is part of that. So the interesting thing here, I think, is that, we've all seen Dansko clogs, they're very popular. They don't really allow for toe extension. So you never have the passive locking mechanism of the foot if you're wearing Danskos all the time. So again, something to think about. I think Danskos are you see them a lot in the hospital, so they have a good reputation as being a good shoe. One problem is that they don't really allow this to happen. So obviously that can contribute or lead to problems. All right, so foot types. Again, the question is, what is normal? And that's kind of the million-dollar question. Here's a couple extremes. I think everybody would agree that this, that looks a little bit cavus. Calcaneus is inverted, and then this looks like kind of a flat foot. Okay? So 3 basic categories, again, just to simplify it. You got normal, which we don't really know what it is, flat foot, and then high arch foot. So just to do a little survey, I want to just get a show of hands. So this is the same person, just a slightly different camera angle. But I want a show of hands. We'll say, is this normal, flat, or pes cavus? So who would say it's normal? And there's, again, I'm not grading anyone. Okay, all the fans of normal, raise your hand. Okay, who would say it's pes cavus? Nobody? Oh, man, I should have got another example. All right, pes planus? Okay, so maybe pes planus. All right, so you're all right. I don't know. But I want to show you this. So this is from behind, okay? So same leg. I'm not sure why I put 2 pictures there, but that is his right leg. Both pictures are right leg. But look at the calcaneus, okay? What position is that calcaneus in? Say it. Somebody say it. Everted? Yeah, it's everted, okay? So, and really my point is that, we all may have a little bit of a different opinion of what a foot type is, but you have to look at the whole picture. And there are some good tools to measure foot posture and things like that. I don't really use them a whole lot because they take up a lot of time. But if you look at this, I'd say that looks pretty normal. At first glance, it's not something I would say, wow, you're really pronated or supinated. But then if you look here, you see that's pretty good calcaneal eversion right there. This is probably, so he's probably standing close to his maximally pronated position, which could be a problem. And you don't really know until you measure it. But this is a good example of, has everyone heard of the watermark test where you look at your wet footprint? It's published in Runner's World. It's kind of the lay Some shoe companies may say, yeah, well, just look at your wet footprint and they'll tell you what kind of shoe you need. This is a good example of how that footprint test is not going to be accurate of what's going on in this foot, because it's going to look like he has a high arch, or maybe even a supinated. But if you look at the calcaneus, he's definitely everted. Okay, so, and again, just an example to kind of show, all right, what are we looking at, and are we all looking at the same things? All right, so we'll talk a little bit about characteristics of pes planus. Excessive calcaneal eversion. That's pretty much across the board. So you're going to have increased flexibility of the foot. You're going to have uneven weight distribution. A lot of times you may see hallux valgus, contracted digits, neuroma, heel spur, heel pain, that heel spur syndrome, which incorporates a lot of symptoms, and also postural symptoms involving the leg, hip, and knee. Okay, so for pes cavus, they're going to have limited pronation, so the foot is going to stay in a rigid position, rigid state, so it's not going to absorb a lot of shock. So this could also lead to uneven weight distribution. A lot of times it's going to be over the lateral part of the foot. You may also see digital contractures. And this is anecdotal, tendency for lateral ankle instability and sprains. This has not been highly correlated in the literature, but I think that we've all seen people who, are major supinators, they tend to sprain their ankle more, just from a clinical. Would anyone not agree with that, just from a clinical standpoint of things you've seen in the clinic? So for whatever reason, they haven't been able to really correlate that with the literature. Okay, so what is pronation? So pronation is really a movement versus a position. Okay, so pronation involves a combination of subtalar eversion, forefoot abduction and dorsiflexion, and the flattening of the anterior medial and lateral arch. All right, so in the closed kinetic chain, what happens with pronation? At the hip, you have flexion, adduction, and internal rotation. At the knee, you have some slight flexion with valgus stress. Lower leg, tibia internally rotates with superior and anterior translation of the fibular head. The talus adducts and plantar flexes. The calcaneus goes into eversion, which we talked about before. And then the mid-tarsal joint, the oblique axis, you'll see adduction and dorsiflexion. The longitudinal axis, you'll see inversion. And the first ray will usually dorsiflex and invert, okay, especially if it's hypermobile. So those are all things that happen as a result of pronation, okay? So pronation is good, right? That's there for a reason. We don't want to completely eliminate pronation. But what happens is when it's considered to be abnormal, which again, we're not quite sure what that is, then we start to have problems. So abnormal pronation is thought to be some of these following points. It may occur at the wrong time. Maybe it occurs too long, so they're pronating through too much of the stance phase, or they pronate too quickly. Excuse me. So the effects of this abnormal pronation can lead to hypermobility, aphasic muscle function, and increased stress on joints and surrounding structures. Okay. All right, so in this diagram, this kind of shows what happens. All right, so we're going to look from the foot up. So overpronation of the foot, you see the leg that internally rotates. Knee moves inward, okay? Adduction, valgus motion there. The pelvis tilts forward, the hip internally rotates, and as we said, the leg internally rotates as well. So think about this diagram and think about the length tension relationship of muscles. Okay, so if a muscle is long, it's usually what? Weak, long, weak, and if it's short, it's maybe overactive or just firing too much. Okay, so if you think about muscle attachments here, even at the hip, what are we going to see at the hip? Somebody just go ahead and call it out. Let's say hip flexors. What are we likely to see? Mm-hmm.
Short and tight.
Did I hear short and tight? Yes. Okay. And how about hamstrings? Okay. Now again, this isn't, this isn't everyone who's overpronating. You're not necessarily going to see this, but I think from an overall standpoint of what's going on, I think it's important to look at that. So, hip flexors, tight psoas, rectus even, you may find that there's some tightness there. And these are kind of things I think that are important to look at when you're dealing with a patient and, they have tight hamstrings or they have tight hip flexors and you just can't seem to get them beyond that. So it's important to start thinking outside the box a little bit about what else might be contributing. So a lot of times it's a position, okay? As you know, you can stretch the heck out of something. If it's in a bad position, it's just not going to function right. So again, something to think about in terms of foot and ankle. And the debate is it hip or is it foot? And Steve and I don't even argue about this. I think we've come to an agreement. But basically, it's both. It's what happens from ground reaction forces with the foot are important. They affect the hip. What happens with the hip is very important in terms of muscle function. So I want to just show you something to demonstrate, see if we can pull this up. I'm not sure if this is going to work, but we'll give it a shot. Steve, do you have sound on this? Oh, sorry, it's not. This is why Jack Black doesn't have knee pain. Sound effects are great. What a glute set, all right? Okay, so we got to go on. That's the main point there. A wonderful glute set. So his glutes are fine. Well, the point of all this is I don't really know. No, the point of it is is that the glutes are a supinator. Okay, so again, if we're just looking at the foot and what it's doing and not looking at the hip, we're missing out, and vice versa, I think. So actually, everybody stand up real quick. And I know a lot of you have done this before, but no one's sleeping. That's good. All right. This is how I figure out if anybody's sleeping. So, all right. So just go ahead and do a Jack Black glute set. The other thing I've heard this called is a CCW. Anybody heard of that? Could crack walnuts. All right. So I want you to squeeze the glutes and just notice what happens with your feet. Okay. All right. Does everybody feel something happening in the feet? Okay. Most everybody. What's going on at the feet? What are they doing? Okay, they're supinating. So again, just an example of the glutes being a supinator. Okay, so if somebody's overpronating, then obviously we want to work on the glutes. Now the opposite is true. If you just try to adduct your knees or feet without moving your feet, you should feel the opposite. So those adductors kind of work the opposite way. All right. So again, that's an example of how everything's tied together. Okay, you can go and sit back down. So somebody liked that clip up here in the front. That's good. Goofy movie, but it's pretty funny. I like Jack Black. Okay, so we looked at closed chain pronation. Now we'll look at closed chain supination, which is basically the opposite. So the hip will be in slight extension, abduction, external rotation. The knee is going to be more in extension with a varus stress, possibly. Lower leg is going to externally rotate. And with the posterior translation of the fib head, the talus is going to adduct and dorsiflex. The calcaneus is going to invert, and the mid-tarsal joint, the oblique axis will planar flex and adduct. Longitudinal axis will go into eversion, and the first ray will planar flex and evert. Sometimes, if you think about your foot rolling out, that first ray is trying to get down to the ground. So the other thing to think about too, which I didn't mention before, but just the knee and lower leg. I haven't really looked too hard in the literature, but just the whole idea of ACL tears and prevention. To me it makes sense. We've also had ACL patients who, their tibias are internally rotating a little bit too much, or they're highly pronated, and it just you almost wonder how that can not have an effect on the graft. So I'd like to see, and again maybe they're out there, I just haven't found them, but I'd like to see studies in terms of prevention of ACL with the use of some kind of orthoses or pronation control. All right, so abnormal supination, just like abnormal pronation, increases, or it could increase at the wrong time. So normally we heel strike when we're walking. We heel strike with the calcaneus slightly inverted. Right after heel strike, the calcaneus should then start to evert, or the foot should pronate or go into pronation to absorb shock. With abnormal supination, the heel strikes and the force continues to go laterally. So sometimes you'll see that up into the knee, like this, a Varus thrust, and the calcaneus remains inverted. And again, this has to do with axes and moment arms. If the ground reaction forces are pushing you laterally, then again you would think that would correlate with lateral ankle sprains, which again we've seen clinically, but not necessarily in the literature. So again, you have decreased shock absorption because that foot kind of stays in a rigid posture. You're not able to adapt as well to uneven surfaces. So you may have lateral symptoms of lower extremity in the calf all the way up into the hip, and then the lateral instability issue. So just real briefly, we'll talk a little bit about evaluation. This is not really in depth, but some of the things that I look at. So weight-bearing observation, we'll look at the relationship of the tibia to the calcaneus. And one of the problems with these measurements is that the intertestal reliability is not very good. It's hard to bisect perfectly the lower leg and the calcaneus because it's not a rectangle. So if we all tried to bisect the calcaneus, we're going to come up with a lot of different things. And that's one of the challenges and why the intertestal reliability is not that great. So we'll measure subtalar joint motion, inversion, eversion, again using that calcaneal bisection. Measure dorsiflexion in prone. I usually try to keep them in subtalar neutral just for reliability standpoint, because if you don't, they're going to usually go into eversion as well, which is what they're doing functionally, but in terms of repeating the measurement, if you keep them in subtalar neutral, it's going to be a little bit more consistent. And then also look at hallux dorsiflexion, because if there's limitation there, then you're going to have some other issues. You also want to keep in mind leg length discrepancy. Is it an anatomic? Is it functional? What's normal? It's normal to have some kind of discrepancy. The question is, at what point does it become relevant? So if it fits with the things that you're seeing, with some of the symptoms, then half a centimeter might be relevant. So don't just rule it out. Just put it into the whole picture. Also, if one foot is is pronating, the other one is supinating, that's going to cause leg length discrepancy. So the leg that's going into pronation is going to be functionally shorter. Okay. Also, if there's a structural leg length discrepancy, sometimes the body compensates by the short side will supinate because it's trying to reach the floor, and the long side will pronate a little bit. So again, it's good to look at asymmetries and try to figure out how relevant that is to what you're treating or what you're dealing with. Look at forefoot to rear foot relationships, forefoot varus or valgus. There's a slide a little bit, right here. So so this is the right foot. Okay, you got your calcaneus here. Forefoot varus, the first metatarsal is higher than the fifth, or more superior. Okay, so what happens is in a compensated forefoot varus, the foot has to come down to the ground. So as the forefoot comes down, the calcaneus then goes into eversion. Okay, so that would typically somebody who's overpronating or has planus will have forefoot varus as well. And the opposite, forefoot valgus, is if that fifth met is more superior than the first. So again, in a compensated pattern, that lateral part of the foot is trying to get down to the ground, and the calcaneus will go into inversion. So you're going to see that with our supinators. Okay, a plantar flex first ray sometimes will affect that as well. You could have a forefoot varus, and if that first ray is stuck in a plantar flexed position, it's gonna look different. Like it may look neutral or even valgus. So I think, okay, if you look right here, this is a little bit of a plantar flex first ray. So you see the plane of the metatarsal heads are here. So if I measured from this point to this point, it would look pretty neutral. But the plane is really going this way, and that first ray is a little bit plantar flexed. Not a huge degree, but that's just something to keep in mind there. And it's also important to look at the first and fifth ray mobility. Are they hypermobile? Are they hypomobile? And also calluses too. Calluses can be kind of tricky. Sometimes it's hard to figure out how they're getting them, but it's some indication of stress. So you can again look at the calluses and say, how does this fit with the whole picture? The clinical picture. All right, so this is a quick and easy biomechanical screen that I think is important, for anybody that you're working with, low back on down. I think the key here is just to be aware of what's going on at the foot. So if somebody comes in with back or hip pain, this is something easy to do. It doesn't take long. But again, it may point to other issues that could be addressed. So the first thing is just the resting calcaneal stance position, and that's the position of the calcaneus in their stance position. We saw that one picture where the calcaneus was everted. So he would be in an everted position, and you can actually measure it. But for the screen, you don't necessarily need to. You're just looking at, are they inverted, everted, or fairly vertical. Maximum pronation test basically is just a half squat, and when the person goes into half squat, they're thought to be in the maximally pronated position that they are during gait. So if you look at their subtalar joint and it doesn't change when they do the squat, then they're standing basically in a maximally pronated position. If they're standing in neutral and they go into a lot of pronation in squat, then again that can lead to other issues. So you can kind of look at what is their normal functional pronation. I'm sure everybody's seen people go into squat and the lateral border of their feet just comes right off the floor. Okay, so and again, it's not just foot, it's not all hip, it's everything tied together. So heel rise test, single and bilateral. You can look for atrophy, look for ability to do it. You want to make sure both sides are functioning fairly equally, and you also want to do a single leg heel rise, which will point to possible posterior tib dysfunction. So again, if somebody comes in with back or hip pain and you find out that they can't do a heel rise on the right side for whatever reason, then that's obviously relevant. Pronation supination test. Again, this is a quick visual, so you can have the person just stand with their knees slightly flexed, arms across shoulders, and then you just have them rotate side to side. Okay, and you should see as they rotate. Actually, everybody go ahead and stand up. We'll do this real quick. So, as you rotate to your right, your left foot should pronate, right foot should supinate. As you go the other way, the opposite should happen. So you're looking for equal motion on both sides. You might find that one foot doesn't supinate when they rotate. Okay, you can go ahead and sit back down. Also, the other thing I like about this too is you can find out hip limitations too. They may say, "Oh man, when I turn this way, my hip hurts, and I didn't even know I had a hip problem." So I like that in terms of just a general lower extremity screen. So if any of those are unacceptable, or if you see some kind of asymmetry that doesn't match up, then you might want to take a closer look at foot and ankle. Okay. All right. So let's talk a little bit about foot orthoses. First of all, I started looking at industry sales, and I was going to try to tie that into the talk, but I just was kind of curious as to what's going on in the industry. It's amazing, like over-the-counter inserts. The amount of money spent on these is just unbelievable. It's in the millions of dollars. So it's obviously a huge market. That's the reason for Dr. Scholl's doing all their advertising. That you wear Dr. Scholl's, and by the end of the day, you feel like $1 million, right? But there's just a huge market there. So I just think there's so many people that have, foot-related pain, and they don't know what to do with it, or don't know what to do about it. And so the only thing they know is what they've seen on commercials. So they go buy Dr. Scholl's, and sometimes they're good. They work. Sometimes, depending on what the function is. But all that to say that I think, the point is there's a huge market for intervention. Okay. Obviously, hopefully we can provide a little better service than, some gimmicky thing at Walmart, where you stand and they tell you what kind of orthotic you need. But anyway, let's move on. So foot orthoses. Again, this is a much more complex function than simply supporting or aligning the skeleton, which is kind of how they've been looked at in the past. So Kirby is a podiatrist out in California. He's kind of the modern guru of foot orthotics, in my opinion. But his definition is, I think it's a good one because it incorporates a lot of these different things. And I know you can all read it, but I'll read it anyway. An in-shoe medical device which is designed to alter the magnitudes and temporal patterns of the reaction forces acting on the planar aspect of the foot in order to allow more normal foot and lower extremity function and to decrease pathological loading forces on the structural components of the foot and lower extremity during weight-bearing activities. It's kind of a mouthful, but he's got a lot of good things in there. And one of the key things here is, especially when what we talked about earlier with outcomes and visits and things like that, there are significant claims that foot orthoses will improve outcome scores and also reduce the length of stay. And I don't have any published data on that, but again, it's something to think about in terms of, all right, how can we get this person better with the least amount of visits, the least I don't want to say least amount of effort, but as quickly as possible, right? Okay, so I want to talk a little bit about theories. This isn't really critical, but just so you know that the theories have kind of molded and morphed and combined over the years. Root was kind of the original, and his idea was that the foot and ankle should function close to that subtalar joint or neutral, okay? And you'll see a lot of stuff in the literature now, like is root model outdated and is it debunked and things like that. So he kind of was the first one to come up with the model of why orthoses work. Kirby came up with a little bit, he built on that and he came up with the idea that there are pathological subtalar joint rotational forces or moment arms, again, depending on where that fulcrum is or where the axis is, will determine what goes on. And if the orthotic can change that, then it's going to help the foot to function better. McPoyle and Hunt, McPoyle's another, he's published a lot in the orthotic literature. They came up with the tissue stress model, which basically showed that tissues were either relieved of stress or stress was transferred through the use of orthotics, and that was why they might be effective. And then Nig came up with this preferred movement pathway model, which says that orthoses function by producing a change in the muscle tuning of the lower extremity. So the interesting thing is, you have root, which started out with kind of a bony structural position, and then you start looking at rotational forces and tissue stress and muscle firing, and so it kind of incorporates the whole thing. And I think that all of those have a component of in terms of possibly explaining what the orthoses are doing. So there is considerable research to suggest that treating patients with foot orthoses cast with the foot in subtalar neutral does in fact make their symptoms improve. One of the issues with research in orthoses is that there's so many variables. You can't control them. Even from what kind of impression was it casted in neutral? Was a crush box used? Was a scanner used? And then what kind of materials were used? And then what lab did it? And what kind of accommodations were made? So there's so many variables that it really makes it hard to study accurately. And I just want to throw some of the research up there that has been done. Some of it's old, but it's still referenced. So there's research that exists to show that foot orthosis can alter the motion patterns of the foot and lower extremity, which I think, if we're talking about muscle and firing patterns, that's kind of an interesting thought in terms of what the orthosis can do. So they have been shown to decrease the maximum rear foot eversion angle, rear foot eversion velocity, ankle dorsiflexion angle, internal tibial rotation, internal ankle inversion moment, also to decrease knee adduction, produce changes in knee external rotation moment, knee abduction moment, and a decreased impact peak and maximum vertical loading rate. So these are all things that have been published. Other research has shown that foot orthosis can alter the contractile activity of lower extremity muscles, again, which I think is very fascinating. They've been shown to improve posture stability. Again, you get those chronic ankle sprains who just never really recovered. They may do well in orthoses to stabilize the foot. And it's also been shown to reduce plantar forces and pressures. That study was interesting because it was 151 subjects with pes cavus. So typically people think, okay, orthoses are for people who pronate or flat-footed. If you're pes cavus, you don't really need it. But this looked at 151 with pes cavus and looked at reducing these plantar forces and pressures. Sometimes you can actually post them laterally to provide a little bit of pronation or inversion if they have the motion. If they're very rigid, you might just have to capture them, capture the foot where their neutral is, and again, it can provide some stability. And then the shock absorption is a big issue with the with pes cavus because, as we talked about before, it's a rigid foot, so you may need to do something with more padding. Okay, just go on a little bit more about research. There's been reported success rates between 50 and 90% in recreational competitive runners. Another study showed complete resolution or significant improvement in 76% of 500 distance runners. So pretty good sample size there. There's been some evidence in terms of prevention, reduction in stress fractures, reduced incidence of femoral stress fractures, and also showed that they can improve symptoms in the female adolescents with patellofemoral pain. Okay, which who here has ever worked with a female adolescent with patellofemoral pain? Probably most, yeah. I mean, it's pretty common. So again, those people do really well. Sometimes they'll do well with just a temporary orthotic or an aquaplast that is molded. We call them aquatemps because they're not, they don't have a lot of structure. They don't need something that's going to be real firm. But some kind of intervention in those cases usually does pretty well. So the orthotic prescription. So we have to decide what kind of material we're going to use. There's a huge variety. This is just a very, very basic list. There's new materials coming out all the time. A lot of EVA foams that are different densities. Some are very dense, some very soft. Again, it depends on what the patient needs. And this is also why it's hard to study because there's just a lot of variability. Graphite, the thin graphite is going to be very flexible. A thick graphite is going to, you can drive a car across it and it's not going to bend. So, graphite is not graphite. It depends on the thickness. These are all things that go into need to be considered with orthotic prescription if you're going to post it intrinsically or extrinsically. Extrinsically means that it's added to the shell, so that's an extrinsic rear foot post. If it's intrinsic, you won't see that white part of the shell is modified and it's actually built into the cast or the positive mold. And then the accommodative padding, there's a huge variety of things there too. This is a prescription order form of Comfort Fit, which is the lab I use. So there's a lot of options there, and there's even more than that. Just to show you, there are additions and accommodations that you can make in terms of padding. These are all basically just additions to the shell. And again, you have the sky's the limit in terms of what you can add or combine. And then there's also shell modifications where you may want to make some kind of change in the shell. So even the medo flange, there's a standard, but you can also make it higher or lower. Heel cup depth, you can specify how deep you want that. And again, when you're trying to look at the research, where are they looking at? So there's a lot of research that shows there's not much difference between over-the-counter or custom orthoses. The problem is, what were the custom orthoses? How were they made? Did they have deep heel cups? Were they all the same? Were they different? And that's the shortcoming of it. It's just hard to account for all those variables. All right, orthotic casting. So I still cast in subtalar neutral, non-weight bearing, so it's suspension cast. The other common methods are a crush box or a foam impression tray where you push the person's foot down and it captures the footprint, or an electronic scanner, which looks kind of like a copy machine. You put your foot up there and it takes a 3D image. Those have come a long way. I think they're actually getting some good results with those. However, it's an expensive piece of machine. So the suspension casting is still kind of the tried and true gold standard in terms of casting. It's not that the other ones are bad or wrong. It's just this has the most evidence behind it. All right, so just to wrap it up, I think the take-home message here is just to be aware of, is this something that your patient could benefit from? Even if it's hip, back, knee pain. If you look at the whole picture and look down at the foot, then you may see, there's something that may be addressed here, and something that we want to include. And the same thing with, going the other way. If you're seeing somebody for foot and ankle, maybe they have orthotics already, or maybe they don't. What are they doing for their hips and further up the chain to strengthen? Just a quick anecdotal note. I've also found too that almost every patient I've seen with pes planus has weak glute medians. Is there anybody else notice that? And I don't know. I think it may be that length tension relationship, because if they're standing, in an sort of with the femoral, the femur internally rotated slightly, that maybe the glute medians are lengthened and they're not firing like they should. So again, that's kind of an interesting phenomenon, but see it almost across the board. So again, look at the whole picture. Think about, okay, is orthotics something that the patient could use? Again, a lot of people do benefit from an over-the-counter orthoses. It kind of depends on what their deformities are, what their conditions are. Insurance is a big deal in that too. If orthoses are covered by their insurance, then to me it's a no-brainer. Let's get them in a pair. If they're not, then the patient has to decide, is this something that you want to pay for, and a lot of them do, or do you want to start with an over-the-counter pair and see how you do with that and go from there. Any patient who calls with you know, on my schedule, knee pain on down, the front desk will almost automatically verify if orthotics are covered. So at least we know, we have that information, which again can expedite their return, possibly improve photo scores and decrease visits. And I think these are just some other articles on hip strengthening. This is a pair that I'm working on. Haven't had too much interest, but don't know why. Anyway, thank you. Thanks for coming. Anybody have any questions? We got a couple minutes before 8 o'clock. Yes, sir.
How quick are you to put somebody on side?
That's a good question. To me, and there's a lot of art to the whole thing too, like even the casting. So, I don't pretend like it's 100% science. I like to consider myself an artist, but anyway, it depends on a lot of things. Like, how long have they been dealing with the issue? If it's something that is an acute injury that you think is going to clear up, then it may not be a big issue. However, if it's an acute injury and you see these biomechanical issues, it may be something that they benefit from for a long time, or even from a prevention standpoint. So, again, there's a lot of factors: insurance, what their history is, what their acute symptoms are they going to wear them? Like sometimes, based on like, somebody in high school, a female in high school, you can tell, she's going to be wearing shoes that won't accommodate orthotics. So is it really worth it? So there are a lot of factors. So just use your clinical judgment and say, is this something that may help in the long term? And then it's probably worthwhile. So.
And from an elite runner standpoint, how quick are you to change them?
Well, there again.
Have to use them.
Yeah, there again. So they have to be open to doing it. And most of the time, most of the people I see are because they've been dealing with a problem long enough. They're like, I just want to get rid of it. I just want to run. So, I haven't had too much pushback, but there's a subset of runners out there that think, I don't want to depend on an orthotic, and I think too, if you are using orthotics, that's not a ticket to not, work on hip strengthening, it's just like wearing a brace almost. You don't want to have someone become dependent on a brace. So, I usually tell people, look, you got to strengthen your hips. If you're wearing these, even if your symptoms go away, don't just think, oh, okay, I don't need to do that. But yeah, it's a good question. Yeah.
What's the wearing schedule for the orthosis? Is your goal to win with every shoe 24/7?
So the second question first. The goal typically is yes, to wear them. Again, that will depend on symptoms or what they're doing. If they're in a job where they sit most of the time, it's not too much of an issue. But if they're having pain or issues every time they're weight bearing or on their feet, then I want them in the orthoses as much as possible. So the wearing schedule typically is an hour the first day, and then each day an additional hour. That varies a little bit depending on the material. So if it's something that's soft or more flexible, it's easier to accelerate that. If it's a more of a rigid device, then they really do have to kind of ease into it slowly. And my feeling too is typically the further up the chain you're trying to affect, the more rigidity you might need in the orthotic. So I'm sure everybody's heard of people who've had really rigid orthotics that just couldn't stand them. I've worn very rigid orthotics that I've done well with. So I think part of it is of making sure it's the right fit and the right adjustment schedule. Does that answer your questions? Okay. Any other questions? Yeah.
Talking about like an analyst athlete who may have custom orthotics.
Right.
Not right away. Use aqua temps.
Yeah. Yep.
Do you give them a specific recommendation just
for over the counter?
Yeah.
Yeah. If they'll do it, like we can bill out $60 to make a pair of aqua temps, which is just aquaplast. We have the templates. We just heat it up in the hydrocollator, mold it to their foot, slip in their shoes, and they're out the door. Which we've had a lot of success over the years with those. And I know you've done a lot of those too, right? So I almost prefer that to an over the counter, just because it's custom, it's easy, they're easy. They can put them in over the inlay of their shoe. If they're gonna do over the counter, I like Superfeet. Pro Step has some good ones, but those are usually the ones I'll recommend for over the counter. But yeah, if we can get them, and we can do at some point we could do an in-service on fabricating aquatemps too, because it's pretty easy. You just need to do it a few times, but it's a nice tool to be able to have, and it's somewhat effective. So, anything else? Yeah.
How long do those last?
Okay, another good question. Again, depending on the material. So the rigid ones will last forever. The softer ones will break down over time. The recommendation is after 3 to 5 years, you should get recasted. So even if the orthotic looks okay, they recommend getting recasted just because your foot changes a little bit. I've had people who've worn them for 5+ years and have been fine, but that's the recommendation. So, and I usually tell people, I say, listen, if you feel fine, I'm not going to tell you need new ones, but the recommendation is that every 3 to 5 years you should get recasted. Oh, those the aquatemps, they're like 6 months to a year, because they'll actually crack. They're not real durable. That's one downside of them. But
do you always cast in weight bearing versus weight bearing?
Yeah.
Yeah.
Yeah. So you get a better idea of what's going on forefoot to rear foot relationship. I've kind of played around with the impression trays and even a semi weight bearing casting. I kind of keep going back to that. It's what I've had the most training with, and it's the one that has the most research behind it. So, but I'm not, 5 years I might not be doing that. I don't know. I don't want to be locked in, depending on what comes out. So I know we're over 8. Guess we got to wrap it up, right? Okay. So if anybody, if you have any questions, just email me or track me down. Again, thanks for coming, and hopefully that was beneficial.
Thank you.
Sure. Thanks, man. All right, thank you. You're where?